Assalamu alaikum doctors, welcome to my YouTube channel MBBS and BDS lectures. Today is the fourth video of revision course of oral and maxillofacial surgery, which is very important for NLE, MDS, NBD as well as for BDS students. In this video we will discuss about oro-antral communication or oro-antral fistula. Now first we will start from a definition of oro-antral communication and oro-antral fistula. Then we will discuss about risk factor, causes and diagnostic methods and prevention and management and different flaps we used and post-op medication for oro-antral communication. Now in last March NLE exam most of the MCQs was come like if the size of the oro-antral communication is less than 5 centimeter, there will be no treatment needed. This MCQ was come. And next the buccal advancement flap MCQs was come. Now what is oro-antral communication? Oro-antral, naam oro mean oral cavity, antral mean antrum mean nose, antrum mean sinus, and communication mean communication. In oro-antral communication, there is a abnormal communication between oral cavity and maxillary sinus. Why? Because the bone present between oral cavity and maxillary sinus is, this bone is fracture. In result there will be abnormal communication, like when like maxillary teeth are more the root of maxillary teeth are more near to the maxillary sinus. When we remove the maxillary teeth, we do not exert extra pressure on palatal root because they are more close to maxillary sinus. In result there will be a fracture of that area. In result there will be oro-antral communication. Next if we fracture the maxillary tuberosity, again there will be oro-antral communication. Now what is difference between oro-antral communication and oro-antral fistula? When initially the communication between oral cavity and maxillary sinus is formed, this is known as oro-antral communication. But when this area left untreated, when this communication become epithelialized, then they become chronic condition, and then they will, it is covered by pathological epithelium, then they will called oro-antral fistula. Now OAC, oro-antral communication. If untreated leads to oro-antral fistula, the communication will epithelialize and become chronic. Oro-antral fistula is not common below the age of 15. Why? There is enough distance between the maxillary sinus and the teeth. Now come to the risk factor of oro-antral communication. There are 4 risk factors. Number 1 is the maxillary molar root close to the maxillary sinus. Second is the pneumatization of maxillary sinus. Third is the divergent and hypercementosed tooth, because in divergent tooth the bone is come between these diverged root. When we remove the tooth, with these root bone will come. And also hypercementose roots have same condition. Next is the root displaced into the maxillary sinus. These are the risk factor. Now come to the causes of oro-antral communication. There are 5 causes. Number 1 is the displacement of tooth or root tip into the maxillary sinus. Second, the alveolus is debride unnecessary. When we remove the tooth, if we debride the alveolar socket unnecessary, over checking or curettage, there will be oro-antral communication. Third, the presence of periapical lesion that has eroded the bony wall of the maxillary sinus floor. Fourth is the fracture of maxillary tuberosity. Part of the sinus get included with the maxillary tuberosity. Mean if fracture of maxillary tuberosity, in result there will be fracture of sinus get included with the maxillary tuberosity. Next is the fifth is the extensive bone removal per extraction of upper posterior impacted tooth or root. Again, there will be oro-antral communication when we remove extensive bone. Now the question is, what is the first thing to check after fracture of maxillary tuberosity? If we fracture the maxillary tuberosity, the first thing will be we should check for oro-antral communication. Next, how do you confirm an oro-antral communication? What are the diagnostic aids? What are the confirmation? Do a nose blowing test. In nose blowing test, we say to patient, occlude the patient nose, ask patient to blow gently through the nose while you observe the area of tooth extraction. If a communication exists, there will be passage of air through the tooth socket plus bubbling up blood in the socket area. Other methods for checking up oro-antral communication are the number one, when the patient rinses his mouth, water seep through the nose. Second, change in speech tone and resonance. Third, after extraction, you find a piece of bone attached to the root end, indicate oro-antral communication. The fourth is the during debridement of the tooth socket, the periapical curate enter a great depth into the socket. Again, it show oro-antral communication. Now come to the next is the number E. A radiograph clearly shows discontinuity of maxillary sinus floor. This is also a radiograph investigation method for maxillary for oro-antral communication, because radiograph clearly shows discontinuity of the maxillary sinus floor. Now come to the prevention of oro-antral communication. There are four methods. Number one, careful radiograph evaluation before extraction. If sinus floor is close to root, do surgical exodontia. Second, careful manipulation with instrument. Do not apply forceps unless there is a sufficient tooth structure present. Third, careful debridement of periapical lesions that are close to maxillary sinus. Avoid luxation of tooth tip if visualization of the area is hindered by hemorrhage. Plus, leave the apical third of the root if get fracture, because they will be itself resolved. But the apical third must not be mobile and not impacted. Fourth, during surgical removal of impacted upper third molar, exposure of the impacted tooth must be adequate so that the forceps exerted during luxation are controlled. Now come to the management of oro-antral communication. First, small oro-antral communication less than 0.5 mm, leave it. It not required any treatment. It will close by blood clot. This MCQ was come in March and early exam. Plus, instruct patient to avoid any positive or negative pressure. Avoid using straws, blowing balloons, and using mouthwash, because they will dislodge the blood clot. In result, there will be small oro-antral communication not close. Next is if there is a large oro-antral communication, mean more than 45 centimeter, buccal advancement flap or bridge pedicle flap or palatal transposition flap plus surgical splint can be used to support the flap. Bridge or palatal transposition flap are done in case you cannot do a buccal advancement. First we do a buccal advancement. If a buccal advancement is not possible due to there is an abscess or fistula, then we go for palatal transposition or bridge flap. Now come to the flaps to close the oro-antral communication. There are three types of flap. Number one is the buccal advancement flap. From buccal, vestibule and cheek, we advance the flap to close the oro-antral fistula. Most commonly used, this MCQ was come, the most commonly used is the buccal advancement flap. Plus, it is the easiest plus less complication method. You cut the mucosa plus the cheek to create a flap and cover the defect. The flap is sutured using horizontal mattress suture. If the flap does not extend to cover the oro-antral communication, cut the periosteum with a blade to gain flexibility and lower the socket wall with a burr. Second is the bridge pedicle plate. Plate is cut from the ridge and then reversed to cover the oro-antral communication from that ridge. This is the bridge pedicle plate. The third is the palatal transposition plate provide best strength. Remember, most commonly used is the buccal advancement plate, and the best strength is the palatal transposition plate, and best result again there will be palatal transposition plate. But it is very difficult to manipulate. The raw area is left to mean the exposed area. From that we take a plate is left to heal by secondary intention, which might be trouble for the patient since they will always touch it with their mouth. These are the plates. Now come to the last parts. Post-operative medication for oro-antral communication. In antibiotics there is a penicillin. In analgesics there is a paracetamol or ibuprofen. And next we give nasal decongestant because due to food lodgement from oral cavity to the maxillary sinus there will be maxillary sinusitis, means there will be sinusitis. Therefore we give nasal decongestant, ephedrine or Operative nasal drop, and next is the steam inhalation. This is all about oro-antral communication. Now today our topic is complete. If you like my video, press the like button and share this video with your friends. If you're new to my channel, subscribe my channel by pressing the red subscribe button and also press the bell icon in order to receive my each new video notification. For watching my videos, I am very thankful to you. Thank you very much.